In this class, we're going to try to put everything together in terms of providing foot and nail care and patient education. So we've talked extensively about the anatomy and physiology of the foot and nail. We've talked about conditions that can affect the health of the foot and nail and the importance of screening for any pathology while providing foot and nail care. So now we're going to kind of walk through putting it all together. How do you do the assessment? And then what are the guidelines for providing foot and nail care? And what are the levels of care that can be provided and who's qualified to provide each level? So let's start by walking through the assessment. So you have a patient who comes into your foot care clinic. You're going to start out by doing a focus history. So you're going to ask them about their medical surgical history. You're going to particularly focus on any conditions that would affect vascular status, skin and nail status, or nerve and motor function. So you definitely want to know, do they have diabetes? How long have they had it? What type? How well is it controlled? How do they manage? Have they ever been diagnosed with neuropathy? Do they have any joint conditions, any arthritis? Are they able to reach their feet? Who does their foot and nail care? All of those things. You want to know if they're having any leg pain or foot pain, if they have any difficulty walking. You want to observe their gait. So as they walk in, or if you walk them to the exam room or to the treatment area, you want to observe their gait. Obviously, you're going to assess the lower extremity. You're going to look for lesions. You're going to look for non-healing wounds. But you want to ask the patient, do you have any wounds? Have you had any wounds? Are you seeing a dermatologist? Any rashes? Anything like that? And as we've mentioned, you want to ask them about routine hygiene. So, are you able to do your own foot and nail care? How often are you able to wash your feet? Are you able to dry between the toes? Are you able to cut your nails? Can you see to cut your nails? Do you have anyone to help you with this? Then you're going to begin the physical assessment. So we've already talked about how helpful it is to observe their gait and their mobility. Most of the time they'll come into a reception area and then you will walk with them to the treatment area or to the treatment room. That gives you an opportunity to observe their gait, whether or not they use any aids such as a walker or a cane, whether or not they have good balance. And then you're going to start your assessment of vascular status, sensory motor status, and status of the skin and nails. We've talked a lot about assessment of vascular status, and we talked about it under lower extremity arterial disease, lower extremity venous disease. We talked about it again. We talked about conditions that could affect the health of the lower extremity, the skin, and the nails. So, putting it all together, now I have the patient in the exam room or the treatment area. So I'm talking to the patient. I've done a limited history. I should have mentioned that in doing the limited history, it's also very helpful to ask them about medications they're taking. So that's something we routinely ask, what medications are you taking? It makes us more aware of medical conditions, chronic illnesses that they may not have mentioned, and also alerts us to any patient taking anticoagulants. Okay, so we've done the history. We've walked them in, we've observed their gait, their balance, their use of ambulatory aids. Now we've got them in the treatment chair and we've taken off their shoes and socks, paying attention to what their footwear looks like, what their socks look like. Hopefully clean. Sometimes you think, okay, these are going in the trash and I'll give you some new ones. So now we have the footwear off, socks off, and so we can observe the lower extremity, the foot, and the nail. Vascular assessment, absolutely essential. I want to know whether or not this patient has normal perfusion. That's going to provide me a lot of guidance as I provide foot and nail care. The patient with compromised perfusion, I know I need to be very cautious with. I'm going to be very conservative in pairing corns and calluses and nipping close to the free nail border. So as I'm looking at the foot and the nail, I'm looking for evidence of vascular compromise. I'm looking for thin, shiny skin. Do I see that? Do I see abnormal patterns of hair growth, like maybe more hair growth on one leg than the other, or a line of demarcation with hair growth? If so, I'm going to ask the patient, have you noticed any changes in how much hair you have on your legs? I'm going to look at the nails. If the nails are thickened, they are non-contributory to the vascular assessment. But if I see nails that are thin with longitudinal ridges, that's consistent with chronic ischemia. So I'm noticing, what does the skin look like? What are the patterns of hair growth? And are the nails thin and ridged? Then I'm going to look at the color. Now, ideally, you'll have the patient in a setting where you can elevate the legs so that you can assess for elevational pallor or cyanosis and for dependent rubor. But sometimes you're in a setting where you have them in the sitting position and you really cannot put them supine. Even if you cannot put them supine, even if you can't check for elevational pallor or cyanosis, you can still check for dependent rubor. So you're going to pay attention to the color. Ideally, you're going to check for response to both elevation and dependency. If you're able to elevate the leg, you're going to check venous filling time. So remember, venous filling time, you put the leg up until the veins in the foot and lower leg collapse. Then you put the leg dependent and you count the number of seconds it takes for the veins to refill. And if it takes more than 20 seconds, that's indicative of significant lower extremity arterial disease. We can always check temperature with the backs of our hands. And if we cannot check venous filling, then we can check capillary refill. Now, capillary refill is not as accurate as venous filling time, but it still does give you some indication of the ability of the arterial system to deliver blood to the tissues and to respond to an empty capillary bed. A lot of times you've been taught to do capillary refill testing by pressing against the nail, but remember that many of your clients will have thickened nails, so most of the time we press the toe pad and observe for return of color, which of course should be less than 3 seconds. So I've looked at the skin, observed patterns of hair growth, checked the nails to see if they tell me anything. I've looked at the color of the lower extremities. Ideally, I've checked for response to elevation, and I've been able to check venous filling time. Minimally, I can assess for dependent rubor and for capillary refill. Then I'm going to check pulses. Even in a setting where you can only place a patient in a supine position, you can still check pulses. So I want to see, can I palpate the dorsalis pedis? Can I palpate the posterior tibialis? If I can't, I'm going to use a Doppler to see if pulses are audible. If I have difficulty palpating, then I'm already concerned enough that I'm probably going to send that patient to vascular for further assessment, even if I can hear it with a Doppler. If I can't hear it with a Doppler, they're definitely going to vascular for assessment. If I'm in a setting where I can place the patient supine and keep them quiet for 10 minutes, and I have access to a handheld Doppler, then I'll do an ABI because it gives me an objective measure of the adequacy of perfusion. And so you remember how you do this. You place the patient supine for 10 minutes. You obtain both brachial pressures using a Doppler stethoscope. You obtain the pedal pressures in both the right and the left leg using a Doppler stethoscope. And then you compare the highest pedal pressure on the right to the highest brachial, highest pedal pressure on the left to the highest brachial. So A over B, ankle over brachial. Since we're always entering it into our calculators, we set it up so that we have ankle on top, brachial on bottom, and we enter from top to bottom. Okay, so if ankle pressures are 90 and brachial pressure is 120, we would enter 90 divided by 120 equals, and you would get an ABI of 0.75. So this is what we were just talking about, calculating the ABI for each leg by dividing the highest of the two pedal pressures for that leg by the highest of the two brachial pressures. You remember your interpretation. What's normal? Normally, pressures in the lower extremity are essentially comparable to pressures in the upper extremity. So the closer it is to 1, the better. Normal range is considered to be 0.9 to 1.3, so frequently the pressures in the leg will be a little bit higher than the pressures in the arm. If you have pressures between 0.5 and 0.9, that tells you you've got some degree of lower extremity arterial disease. If your ABI 0.8 is relatively mild arterial disease. If your ABI is 0.53, it's moderate progressing to severe arterial disease. What about if it's over 1.3? Then you probably have calcification, which is very common in the diabetic population and in patients with renal disease. So if it's greater than 1.3, they definitely need a vascular consult. And if it's less than 0.5, they have very significant arterial disease and need urgent vascular consult. So going back to this, remember that ABI is a screening test. It does give you objective data, measurable data. If your patient's normal, then they do not need further vascular workup unless there are clinical indications. But if ABI is greater than 1.3 or lower than 0.5, they need an urgent vascular consult to determine what's going on. If the ABI is between 0.5 and 0.9, they should still see vascular, it's just not as urgent. So, who goes to vascular? Anyone who falls outside the range of normal. Normal, 0.9 to 1.3. Less than 0.9, yes, you want a vascular workup. They have some degree of lower extremity arterial disease. Greater than 1.3, yes, you want a vascular workup. They have calcification. Less than 0.5, very urgent vascular workup. You also want to check for edema. So when we talk about doing a vascular assessment, we tend to focus on the arterial side of the vascular bed, but we don't want to forget the venous side. Venous return is also very important, and we know that an early sign of venous insufficiency is edema. Because when we lose normal propulsion of blood back to the heart, we get backflow into the superficial veins, we get back pressure on the capillary bed, fluid leaks out of the capillaries into the tissues. So we're always going to check for edema. 1+ means that when you press into the tissues, you get a 1 millimeter depression that lasts less than 10 seconds. So not so bad, minimal depression, rapid resolution. 2+ means that you've got a 2 millimeter depression that lasts 10 to 15 seconds. 3+ means 3 millimeters that takes 1 to 2 minutes to resolve. 4+, very severe, 4 millimeters and more than 5 minutes for resolution. So you start with your vascular assessment. What does the skin look like? What do patterns of hair growth tell you? What do your nails look like? What's the color? What happens with elevation? What happens with dependency? What's your venous filling time? Or cap refill if you can't do venous filling. What about your pulses? And ideally, get an ABI. Always check for edema. Okay, let's move ahead. What about sensory motor assessment? Now this is essential on the intake visit for any patient who comes to a foot and nail center or any patient with a lower extremity wound. It should be done on follow-up if that patient has a known condition resulting in neuropathy such as diabetes, B12 deficiency, history of alcoholism, or if that patient had abnormalities at the time of intake. So just a quick review. Monofilament testing, probably the most critical element of sensory motor testing. So you use the monofilament, the 10-gram monofilament. Most centers test at 10 sites: 1st, 3rd, 5th toe pads, 1st, 3rd, 5th mat heads, at midfoot, medial and lateral, and over the heel if there's no callus, on the dorsum between the 1st and 2nd toes. You do steady pressure till it forms the C shape. You remove it and wait for their response. We'll go over this again when you're on site. Critical things: do not hold the foot. You want to be sure the only thing that's touching the foot is the monofilament. Have the patient close their eyes. Don't prompt the patient. Don't say, "Did you feel that?" It's instinctive to say, "Did you feel that?" And then they're like, yeah. So instead, if I've done 3 test points with no response, I'll stop and say, "Have you felt anything yet?" Because sometimes the patient will say, "Yeah, but it didn't really hurt." Then you have to review the instructions. I want you to tell me any time you feel me touch your foot. Okay, if there's no response to 5.07, what does it mean? It means they've lost protective sensation in that area. Protective sensation is what alerts you to the fact that your shoes are too tight, that your toes are rubbing, that your shoe is rubbing against the heel, that there's a little teeny pebble or a rough spot that's irritating your foot. Protective sensation is what keeps you from developing ulcers and lesions. If you have access to a 6.10 and the patient does not respond to 5.07, you may do testing with 6.10. If they fail to respond to 6.10, it means they're insensate and very high risk for severe trauma. These are the patients who don't know that they just put their foot into boiling water. These are the patients who don't know that they've walked onto a nail and the nail has penetrated the shoe and the foot and has nailed their shoe to their foot. They don't know until they try to take it off. So, not critical to test with 6.10, but if you have it and if they fail 5.07, you may test with 6.10 because it gives you additional data. Bottom line, for me, if I have a patient who has lost protective sensation, meaning they have areas of the foot that do not respond to 5.07, I'm really ramping up my patient education about the importance of protective footwear at all times. Shake out your shoes before you put them on. Have your shoes professionally fitted. Check your feet at the end of the day, all of those things. At the first visit, if at all possible, you also want to check for vibratory sense. And if you're doing routine surveillance for patients who are at risk for neuropathy, you would want to do vibratory sense testing at each visit because, as you remember, vibratory sense is typically the first sensory function that is lost as neuropathy develops. So it's a heads up, it's a warning to you and to the patient. Okay, this patient's starting to develop neuropathy. We've got to really ramp up our glycemic control to prevent progression. So you know how to do it. You hold it by the stem, you smack it against your hand until you can feel it vibrating. You put it either at the base of their great nail or over the bunion bone. You ask them to tell you what they feel. You ask them to tell you when the vibration stops. You'll be able to tell when the vibration stops because you can feel it too. Or you can actually stop the vibration by pinching the prongs together. We'll go over that on site. Position sense, critical for us to know where our feet are in space so that we can protect ourselves against falls. So here we have the patient close their eyes. We move the great toe back and forth to the right, to the left, and see if the patient can tell us what direction the toe is pointing when their eyes are closed. If they have lost position sense, we ramp up our education about fall prevention. Hold on to the rail when going down steps. Watch when you're walking on rough terrain, those kinds of things. Okay, so we've done our vascular assessment. We've done our sensory motor assessment. We've done sensory component of sensory motor assessment. What about the motor component of sensory motor assessment? That's all a physical exam. So what are we looking for? We're looking for deformities, and we're looking for callus formation. Because remember what your motor nerves do, they control muscle function in the foot, and muscles maintain normal contours, maintain normal gait. So when we have a patient who develops motor neuropathy, what do we see? We see flexion contractures of the toes, hammer toes. We might see overlapping toes. We might see claw toes or mallet toes. We might see callus formation over the metatarsal heads. So here you see callus formation over the fifth metatarsal head, and you can see that this patient has very abnormal prominences over the first metatarsal heads. You look for altered contours like Charcot foot. You look for overlapping toes, all of those things. Very helpful to also assess range of motion. So you can just ask the patient, okay, point your toes toward your knees, point your toes toward the floor. Make a circle with your foot. Then, here's the patient's foot, here's my hand. Okay, I want you to push my hand down. Okay, now I want you to push my hand up. So you can assess strength and range of motion very quickly. You can assess reflexes if you're in a position to do so and you have the reflex hammer. It's considered optional in most settings, but of course remember how you check the patellar reflex. So you have them sit with their lower leg hanging down, you tap just below the knee and you expect to see knee jerk. Achilles is the ankle jerk response. So you support the foot, you tap over the Achilles, and you feel the foot jerk. What about Babinski? So you take the end of the hammer and you run it along the plantar surface of the foot, and you should see toe flexion. So you can do those if you're set up to do them, but don't feel as if they're essential. Now we're moving on to assessment of the skin and the nails. So I'm looking at their feet. I'm looking to see, do they have normally hydrated skin? Is the skin overhydrated and wet? That's uncommon. More commonly, we see very dry, cracked skin. That has a lot of implications for our skin care and education. We're looking for calluses and for corns. If we see calluses or corns, we know two things. First of all, we have to pair the callus, pair the corn. We'll show you how to do that on site. Secondly, we've got to figure out why are they developing calluses and corns. It's something about their footwear. They're getting repetitive trauma. So either they need a different insole, they need a shoe with a deeper toe box. There's some modifications that need to be made in their footwear to prevent this vicious cycle. We want to assess the fat pads over the metatarsal heads and the heel. See, are they normal? Are they thinning? Are they absent? If they have thinned or absent fat pads, then they need sole and insole that provides cushioning. We have to compensate for loss of the fat pad to prevent callus formation, ulcer formation. And of course, we're very alert to any lesions. So do I see fissures between the toes? Do I see evidence of tinea pedis on the plantar surface? Do I have ulcers on the tips of the toes or on the bottom of the foot? And then the nails. That's what they came in to get fixed, and so many times there are abnormalities in the nails, so we want to notice the length, which is hard to miss if the length is excessive. We want to notice the contours, so do they grow straight? Do they tend to curve down and around? Do they have a ram's horn pattern? How thick are they? Are we going to be able to just nip them with our nipper, or are we going to have to thin them first? What color are they? If they're yellow, brown, brown, black, yellow, white, they probably have a fungal infection. Do you have normal integrity of the nail, or do you have deep splits in the nails? Are there chips taken out of the nails? That tells us to be very careful when we're nipping. What about their foot hygiene? Are their feet clean? Is there a lot of debris between the toes? A lot of toe jam? That's not good. Then that is a major red flag in terms of patient education. What about the cuticles? Are they intact? Are they torn? Fortunately, on the toes, cuticles are usually intact. You see a lot more cuticle damage on fingernails because people have access to their fingernails. They don't have as ready access to their toenails. Any evidence of fungal infection in the nail, and any evidence of an ingrown nail. And finally, you're going to assess footwear. Very helpful to have the patient stand on a piece of paper. You can trace around their foot, and then you can compare the foot tracing to their shoe. If their shoe fits inside the foot tracing, then their shoes are too small. So you can do that. You can look for other indications that their footwear is incorrectly sized. For example, if all of their toes are reddened or bruised, that suggests they're getting constant trauma against the end of the shoe. If they have a bunion and the skin over the bunion is extremely red, if it's non-blanchable, so they essentially have a stage 1 pressure ulcer, it tells you they need a shoe with a wider box for that section, a wider toe box. So you pay attention to the size, you pay attention to the adequacy of the toe box. If the patient has corns on the tops of their toes, or if they have areas that are red or bruised on the tops of their toes, then the toe box isn't deep enough. They have it over the bunion, it's not wide enough. Pay attention to wear patterns, to the conditions of the insoles. Many times the insoles are worn out and need to be replaced. If they're worn out, they're not providing any cushioning. What are the shoes made of? Is the fabric of the upper breathable and conformable? Now, most of our patients don't have wet, sweaty feet, but they still need a conformable upper if they have any toe deformities at all. So they need something that gives. So either kind of a fabric upper or a leather upper that has some conformability. And you want to pay attention to their socks. So are they clean? Do they have holes? If they're wearing hose, are there seams? And are those seams causing any problems? So I know you've seen patients, I've seen patients where if I have any socks available, the socks on their feet are going in the trash and they're going home with new socks. We've already talked about the importance of asking the patient about their routines. How often do they take a bath or shower? Can they reach between their toes, to dry between their toes? A lot of patients will tell you no. So then you can say, could you take a towel and wedge it between your toes and treat it like dental floss? So floss between your toes. Could you do that? No. Do you have a little fan? Could you sit with your foot in front of the fan? How can we get the skin between your toes dry? Do you have anyone to help you? Do you routinely use emollients? Do you put lotions or creams or Vaseline on your feet? How often do you do it? When do you do it? We want you to do it right after your bath, but we want you to avoid placing it between the toes. So ideally, pat your feet dry, apply the cream or lotion or Vaseline or whatever, and then take your towel and dry well between the toes. Who does your nail care? So a lot of times patients will tell you, I tried to do it, you can see, I think that's how I got that cut. I was trying to do it, but I couldn't really see and I couldn't really reach. That gives you an opportunity to educate them about why it's so important for them to have their nail care professionally done. And finally, are they routinely seen by a podiatrist? Because many patients will need a podiatric referral for different issues. Now, there's a concept called levels of care. This was developed at the Medical University of South Carolina. It will be very helpful to those of you who want to develop a comprehensive program for foot and nail care, and you know you cannot do it all. So here's the basic concepts. You have a variety of practitioners who have different levels of skill and knowledge. You have patients who present with problems of varying complexity. So you know, if you've done foot and nail care at all, that some patients are pretty straightforward and others are very complex. So the whole goal with this levels of care concept is to match the patient's level of need with a practitioner who's prepared to meet those needs. So let's look at the 3 levels. Level 1 care can be provided by any RN with very basic education. Patients are eligible for level 1 care if they have intact skin, so no real lesions, no ulcers. They have intact sensation, so they respond to the 5.07 monofilament. They have palpable pulses, and they have relatively normal nails. What do they need? They need assessment, education, maybe some assistance with basic nail care. So what would the nurse be doing? Annual assessment. So on the annual assessment, the nurse should know to look at skin, hair, nails. Check pulses. Check for edema. Check capillary refill. Depending on the setting, the nurse might also do ABI testing and venous filling time, but certainly the basic vascular assessment can be completed by any RN. Any RN can complete that basic sensory motor assessment once he or she has been taught, so they can test with the 5.07. They can do vibratory sense testing. They can do position sense testing. They can look at the contours of the feet. They can screen for callus formation, which would tell you that there was abnormal weight bearing. They're going to assess foot and nail status and to be sure that the patient's in appropriately fitted footwear. They're going to teach the patient how to care for their own feet, how to inspect their feet, and what to do if they find any issues. Level 2 care. That's a step up, and a lot of RNs would not be prepared to provide level 2 care. So these are patients who do have palpable pulses, but they might have evidence of sensory motor neuropathy. They might have skin complications like a fungal infection. They might have long, thick nails that require higher level intervention. They might have corns or calluses. So they still need assessment, everything we've talked about. They still need education ramped up to address their special needs. But now they definitely need assistance with nail care and with corn and callus care. Who can do this? Well, certainly you can do it. You're an RN with special training. You could turn around and teach nurses on your staff to provide this level of care. Depending on your care setting, you might need an order from a physician, or you might not. Advanced practice nurses, of course, would be covered to provide this care. So now what are you doing? Well, now you're going to be assessing them 3 times a year, so they should have a callback every 4 months. You'll be teaching them how to care for their feet and their nails, how to make sure that their shoes are appropriately fitted. You will definitely be trimming the nails. So when they talk about nail debridement, they're talking about a combination of trimming the nails and thinning the nails. You can thin the nails with emery boards. You can thin the nails with a grinding tool, like a Dremel drill. But there's issues with the Dremel drill. You have to know if you're covered to use it, and you have to consider infection control issues. We'll come back to that. They are covered at this level to buff corns and calluses, but not to pare. So buffing means that you take the emery board and you go in one direction across the corn, across the callus to take it down. Or you could teach the patient to use a pumice stone. And education regarding footwear. Most of your patients will fall into level 3. So these are patients who have diminished perfusion and or diminished sensation. They definitely have skin and nail problems, so they have corns, they have calluses, they have fungal infections, they have thickened nails, they might have ingrown nails, and most of them will have some foot deformities. So these patients are typically assessed every 3 months, so they come back 4 times a year. They require intensive education, they require high-level skin and nail care, and they require referrals to assure appropriately fitted footwear. So this is you, an expanded role RN. It could be an advanced practice nurse, or a certified wound ostomy continence nurse, or a certified foot care nurse. So we've already talked about some of the interventions: assessment 4 times a year, intensive education. You'd be clipping and thinning the nails, so usually using the drill or a very large, thick, abrasive emery board. You'd be paring corns and calluses. You'd be doing basic management of ingrown nails, and education and referrals regarding footwear. At this level, you are prepared to manage fungal infections with over-the-counter agents. So if somebody comes in and they have chronic tinea pedis, so they have those dry, circular, scaly lesions all over the bottom and the sides of their foot, and they have some little fissures between the toes, yes, can you identify that as tinea pedis, and can you provide the patient with appropriate recommendations regarding over-the-counter antifungal products and how to use them? Yes. What if you felt like the patient needed a prescription agent? Well, then you have to refer them unless you're advanced practice. We'll come back to specific management of ingrown nails, but at level 3, you are prepared and qualified to do basic preventive care for nails that are C-shaped. We're trying to prevent ingrown nails, or basic management of ingrown nails, and or to initiate an appropriate referral if the patient comes in with an acute infection related to the ingrown nail. And here's the referrals. So you are prepared to refer to the podiatrist if they have a difficult fungal infection, they need prescription products. If they have a painful ingrown nail that you can't manage on your own, you're going to recognize patients who need a referral to the podorthist or the orthotist for footwear and insole modifications, and you're going to refer to vascular for patients who have lower extremity arterial disease or venous disease. So let's say, okay, I want to do foot and nail care. There's a few things you want to check out before you go get your equipment and get set up to practice. First of all, check with your state board of nursing to determine if there are specific credentials that are required, if there are any limitations in your scope of practice within your state. Most of the time, certification as a foot care nurse is very beneficial, because if you pursue certification as a foot care nurse, you clearly have proof of a level of knowledge that's required to provide appropriate foot care, and is provided by an accredited certification board. So if you're going to provide foot and nail care, we strongly encourage certification. You have to think about infection control. Many of these patients will have fungal infections. So you don't want to be spreading fungus around the world. Here's the basics. Gloves are optional if your skin is intact and their skin is intact. But if they have any wounds, any open lesions, or if you have any open lesions, you have to wear gloves. Some people routinely wear gloves, which is fine. If you're using a Dremel, you have to realize that when you're filing down the nail, thinning the nail with the Dremel, you're going to create a cloud of dust. And if they have a fungal infection, it will be a cloud of fungal dust. You don't want to be inhaling it. And there are concerns that use of the Dremel might increase your risk of pulmonary fungal infections. So minimally, you should wear a face shield and a mask. You should be aware that if you do start a foot and nail clinic, it might be helpful to get one of the Dremels that has a vacuum attachment so that most of the dust goes into the vacuum. You would still wear the mask and the shield. In some centers, the decision has been made that they won't use the Dremel at all because of infection control concerns, specifically the risks of the practitioner. In those centers, they'll use alternatives for thinning, thickened nails, and we'll come back to that. And you have to think about disinfection of your equipment. You want to make sure that you never ever transmit organisms from one patient to another. So let's talk about that. Many foot care practitioners start out by providing a brief soak. And this has multiple advantages. It softens the nails, it assures that you start out with clean feet, all of those things. However, you have to think about, well, how am I going to do that? And what about the equipment I'm going to use? So there are two commonly used approaches. One is to use vinyl tubs. Put them in the vinyl tub with warm, possibly sudsy water. After you take them out, rinse the vinyl tub, dry it thoroughly, soak it with an antiseptic such as Lysol. So literally spray all surfaces until wet and allow it to air dry. That's bactericidal, fungicidal, virucidal. Or a lot of clinicians are now using disposable liners for the tubs, which would be faster. You could just slide the tub into a disposable liner, fill it with the water, soak the patient's feet, take the patient out, take the tub out of the liner, put it in another liner, and you're ready to go with the next patient. What about the equipment that you use to actually explore the nail board or trim the nails, possibly to thin the nails? So anything that's stainless steel, like your nippers, okay, your clippers, your spatulas, that's what we use to explore the nail board, or your Dremel bits. You're going to wash them well, rinse them, dry them, and then you have two options. You can either autoclave. Well, if you're practicing on your own, you're probably not set up with an autoclave. You could put them in a dishwasher. That would get them completely clean. Some people hate the idea of putting foot care stuff in their dishwasher. I'm just putting it out there. Or you could do cold disinfection with Cydex, but you have to follow the manufacturer's guidelines exactly. So either of those are appropriate. So then the next thing that comes up is, well, what about payment? Can I get reimbursed for this? So if I provide foot and nail care, can I file on the patient's insurance? Or can the patient file on their insurance? And the answer is generally no. So here are the guidelines. Third-party reimbursement from insurance, from Medicare, is available only in outpatient and long-term care facilities. So if you provide foot care in the hospital, and I sometimes provide limited foot care in the hospital, but the hospital's not going to get additional reimbursement for that. However, if I'm providing foot care in an outpatient clinic, sometimes we can get reimbursement. Here are the guidelines. If I'm going to bill for foot and nail care, either in the outpatient setting or in long-term care, I have to be an advanced practice nurse, or I have to be practicing under the direct supervision of a physician or an advanced practice nurse. So what does that mean? Well, what if I went to a long-term care facility? Could I just go on my own? No. If I'm not advanced practice, I would need to go with an advanced practice nurse or with a physician. And maybe we would initially make rounds on 12 patients. And then the physician or the advanced practice nurse would say, okay, Dorothy, you do patients A, C, F, G, H, and I'll do these others. So that provider is in the agency at the same time I am. I can go get them if I need them. So we can jointly provide care to 12 patients. The provider, the MD or the APN, can bill for that care. And I can negotiate payment with the APN or the physician. But here's another big, important caveat. Many patients will not meet the criteria for reimbursement. So insurance, Medicare, does not pay for routine foot and nail care. They don't pay the podiatrist, they don't pay an advanced practice nurse, they don't pay anyone for routine foot and nail care. They only pay for foot and nail care if the patient has medical conditions that make it unsafe for them or a family member to provide their foot and nail care. In other words, it has to be a patient with something like diabetes and a major complication like diabetes and arterial disease, diabetes and significant neuropathy. Can't be diabetes alone. So that has major implications. That means that a lot of patients, you can't bill the third-party provider, period, no matter who you are. So you just have to think this through, and I'm going to give you an option in just a minute. So let's say that I'm in an outpatient clinic and we have lots of diabetic patients with neuropathy, lots of diabetic patients with significant arterial disease, and all of them would benefit from foot and nail care provided by a professional. And we're very interested in doing this, and I would be working with a physician, I would be working with an advanced practice nurse. Okay, yes, you can definitely set up billing because the majority of your patients are going to meet the criteria, and that will generate some revenue for your clinic. There are CPT codes established for nail debridement and for paring of corns and calluses. I have to warn you that nail debridement does not generate much in the way of money. It's something, and something is better than nothing. So in some centers, they decide, yes, we're going to bring the patient back every 3 months because they're diabetic and they have neuropathy. So we need to be screening them every 3 months. And we're going to provide foot and nail care. But we're going to bill for the clinic visit instead of for the nail debridement because we're not going to make money billing for the nail debridement. So you would want to sort this all out if you're providing care in an outpatient clinic or in a long-term care facility. If you're in an outpatient clinic, you want to sort out reimbursement issues with the reimbursement specialist, the insurance specialist for your clinic. If you're going to long-term care, you want to sort out reimbursement issues with the supervising physician or advanced practice nurse. So, is there any option for payment? Yes. How many nail salons do you see? They're everywhere. They don't file for reimbursement. The patient pays out of pocket. People pay every week to get a manicure, to get a pedicure, or every 2 weeks. When patients go to the podiatrist to have their nails clipped, they pay out of pocket unless they meet those specific criteria, unless they're a diabetic with arterial disease. If not, if I take my mom to the podiatrist and she doesn't have a major medical condition that necessitates professional nail care, the podiatrist will do her nail care, but she's going to pay out of pocket. That means you can provide foot and nail care on a self-pay basis, and many people do. I know people who that's all they do, is foot and nail care, self-pay. So they set up their fee schedule. Here's how much I charge for the initial assessment and the initial visit. Here's how much I charge for follow-up. You decide cash only, or you can set up a PayPal account or whatever. So yes, can you get paid? Yes. Can you get reimbursed? Probably not. Okay, not by the insurance company, but you can get paid by the patient. And you have to think, for many people, you're a much better deal, because if they're in assisted living and you come to them, that's much easier than making an appointment and going to the podiatrist. And you'll probably provide them with gentler foot care and some tender loving care, foot soak, lotion massage, conversation that they might not get at the podiatrist. So yes, you can do this and you can get paid. Okay, in our last few minutes, I'm just going to walk you through what you do when the patient comes in, how you manage the various issues. So they come in, you sit them down, you sign them in, you get informed consent if they haven't already done that. And then you're going to sit them down and either do a brief soak in warm sudsy water or wash their feet. Then you're going to do that brief vascular assessment. So they're sitting. Look at the color of their lower leg and their butt. Is there any dependent rubor? If they're in one of those fancy chairs and you can elevate the leg, look for elevational pallor. Check warmth. Look at the skin, hair, and nails. Do venous filling time if you're able to elevate the leg. Check pulses. Do ABI if you're in a setting that permits that. Always check for edema. Check for hemosiderosis. Then you're going to do your sensory motor. Okay, I'm definitely going to do testing with my monofilament. I'm going to check the foot contours. I'm going to check their gait. I'm going to look for deformities. I'm going to look for callus. Depending on the setting, I will also do vibratory sense testing, range of motion, muscle strength. I might do reflexes. So you'll have to decide what's the setting, how much can you do. I'm going to check their skin. I'm going to look to see, is it dry, is it wet, is it normal? It's usually dry. We could wish it would look like that, but it usually doesn't. I'm looking for calluses, I'm looking for corns. I'm checking between the toes, looking for fissures. I'm looking for lesions. I'm looking at the nails. How long are they? How thick are they? Do they have abnormal curvatures? That tells me what I have to do. And then I'm going to take my little spatula and I'm going to go around and I'm going to assess my free nail border and remove any debris underneath the nails. A lot of times people ask me, well, how do you know what to do first? Like, should I thin the nails and then clip them? Should I clip them and then thin them? What's the best order? So this is our suggested pathway. Start out, remember you have to know where your free nail border is. What if I have callus right along here? Then I've got to pare the callus. Any callus that's obstructing the free nail border has to be pared before I do any nipping. Also, if I have very thick nails, I have to thin them before I can clip them. So I have to remove obstructing callus and I have to thicken nails before I can proceed to clip the nails. When I start to clip, and you're going to do this on site, you're going to clip from side to side, taking small bits at a time. You don't want to start in the middle. You want to take large bites because then you're much more likely to cause splitting of the nail. Common question, how do I avoid going too short? How do I make sure I didn't leave it too long? You follow the free nail border. That keeps you from getting it too short. In general, when I get through clipping the nail, I should be able to touch, and I should touch toe pad before I touch the nail. If I touch nail first, it's probably hitting against the shoe. Then I'm going to pare corns and calluses. I'm going to address any C-shaped ingrown nails. Now this is a real challenge, managing your ingrown nails, and basically we have to show you how to do it, which we will do on site. But this just shows you what you're dealing with. So with the ingrown nail, you've got the nail growing down into the tissue, and then you have an area of inflammation, the tissue's response to that foreign body. If they're acutely infected and in a lot of pain, I probably can't do anything except refer them to the physician for antibiotics and definitive management. But if they come in and maybe they have some inflammation but no acute infection and it's tender but not acutely painful, then my goal is to lift out the nail that's digging into the tissue. So I want to lift the nail, I want to trim it. So I'll take my spatula first and see if I can kind of lift that nail out of the tissue. I'll slide my nippers underneath that little corner and try to clip out the corner. If these are my nippers and this is the nail, I want to be sure that my nippers extend beyond the little piece of nail. I don't want to leave any hooks in the tissue. Again, we'll show you this. So I'm going to slide my nippers in right along here. I'm going to take out that corner. Sometimes I can't get it all at once. I have to do a little bit, smooth lift, a little bit, clip a little bit more, smooth. But at the end, I want the nail out. Okay, I might have to come down to here. The podiatrist would do this, but I'm going to do more like this. Take out the nail that's causing the foreign body reaction. So nip it out, take my emery board, smooth it so there's no sharp edges to dig down into the tissue. And then ideally, we want to take a little strip of an alcohol pad or cotton ball and tuck it into the space between the nail and the skin. And that acts as a spacer and keeps the nail from growing back down. We call it behavior modification for badly behaved nails, and we'll show you how to do that. We've said that if you're going to use an emery board or the Dremel to thin an area of callus or to thin a corn, you don't go back and forth because that causes a lot of friction in the underlying tissue. You buff in one direction. If the corn is thick, if the callus is localized, it's usually much better to pair with the scalpel than to buff. But if you have a thin callus, a thin corn, then buffing can be very effective. We've already talked about the importance of checking between the toes. You want to check for fissures, evidence of a tinea infection. Also make sure that you didn't leave any nail fragments behind. You want to leave smooth, clean, dry skin. And of course, at the end, we're going to put an emollient onto the skin, not between the toes, but to all of the skin on the foot. Specific problems, you'll get a chance to deal with this on site. Many patients have thickened nails, and we've said that a lot of times we'll use a Dremel to thin the nails. But what if you're in a setting where that's not safe, like an inpatient setting? Or what if your clinic has a policy against use of the Dremel? There's a product known as 3-Way that will thin the nails, soften the nails. It won't thin the nails, excuse me. It will soften the nails. So you can soak a cotton ball with the 3-Way, put it on top of the nail, let it sit there while you trim other nails, and then you can go back and it softened the nail enough that a lot of times you can nip from the top down. Just being very careful not to go too far down. You can also, if you're not equipped with 3-Way or you don't feel comfortable doing top-down nipping, and you don't have access to a Dremel for whatever reason, you can get an emery board, and you can get those big black emery boards from Sally's Beauty Supply, and you can use that to thin the nail. That's what I do if I'm doing nail care in the inpatient setting and I have a patient with very thickened nails. We've talked about use of Vicks Vapor Rub to treat fungal infection of the nail that you apply it around the cuticle daily after bathing. You know that's an off-label use of Vicks Vapor Rub, but very safe. You have to think about equipment if you're going to start doing foot and nail care. So what you need for level 1 care, which is very basic, you really need a Doppler so you can do good vascular assessment. You need a tuning fork if you're going to do vibratory sense testing, and you absolutely have to have monofilaments. Level 2, now you're doing more assistance with nail care, so you're actually you're actually trimming the nails, so you need your nippers. You need spatulas or orange wood sticks, so you could use orange wood sticks. Spatulas have the advantage of being thinner, and you can disinfect them because they're stainless steel. So spatulas or orange wood sticks. Pumice stones are very helpful, but you can't reuse them, so many times we'll just use emery boards, and we'll teach patients about use of a pumice stone. And then level 3, if you're going to grind down your thick nails, you need the Dremel motor tool. Because you're doing that, you'll need masking goggles. If you decide against using the Dremel, then the masking goggles are not as critical. You'll need disposable scalpels to pare corns and calluses, and you'll need silver nitrate sticks to control any minor bleeding. Throughout your foot and nail care, you should be doing patient education. Many times patients are not providing appropriate foot and nail care, sometimes because they don't know what to do. So you want to talk to them about the importance of routine use of emollients and then drying between the toes. And you want to specifically ask them, walk me through, tell me how you do it, tell me what you think you could do. What if they have a recurrent callus over the third metatarsal head? You want to teach them about use of a pumice stone or an emery board in addition to having their footwear reassessed. A lot of the education relates to footwear. We want to make sure that people are wearing appropriately fitted shoes, and people tend to fall in 3 categories, and you provide a little bit different education for each category. If you have somebody with intact sensation and no major deformities, these patients or these clients are buying their shoes off the rack very appropriately. But they still need to be sure that their shoes fit correctly. So you want to give them some tips. Buy your shoes at the end of the day, because otherwise if you buy them early, your feet tend to swell toward the end of the day. Your shoes might not be big enough. So buy shoes toward the end of the day. Either have your feet measured or stand on a piece of paper, trace your foot, and use that foot tracing to make sure that any shoe you're considering buying is big enough. You also want to assure appropriate fit in the forefoot. So one really good thing to do is to just take your thumb and forefinger and press in at the widest part of the shoe. The widest part of the shoe, which you can visually determine, should also be the widest part of your foot. It should be the bunion bone to the bunionette bone. Okay, the first met head to the fifth met head, lateral and medial. Okay, so you stand down, you feel to see, okay, does it fit there? Does the widest part of the shoe line up with the widest part of my foot? If so, you almost always have enough room in the toe box. So then you tell them, so all these things, either measure your foot, use the tracing, get your shoes at the end of the day, check at the widest part of your foot to make sure it lines up with the widest part of the shoe. Get up and walk around the store and make sure they feel comfortable. because if they don't feel comfortable in the store, they're not going to get better when you get them home. Second category is the patient who has intact sensation but does have some deformities, some significant deformities. So maybe they have hammer toes or they have a bunion. Then you've got to give them specific guidance. You go through everything we've gone through, but if the patient has hammer toes, you have to say, look at the contours of your toes. When you buy shoes, you have to make sure there's enough room for those toes. Look at the toe box. Make sure the toe box is deep enough. If they have a bunion, say, notice your foot's much wider here. You've got to carefully test in the store to make sure that the widest part of the shoe matches up to the widest part of your foot. You've got to do the tracing, remember. Hold it up, make sure that the shoe accommodates that deformity. Pay attention when you're walking around. Does it feel like it's rubbing? Don't get those shoes. And then for patients who have significant deformities or diminished sensation, they shouldn't be buying their shoes off the rack at all. They should have their shoes professionally fitted by a podorthist, an orthotist, whatever. So good fit we've talked about. Ideally, they get measured. Everybody needs a toe box that accommodates their toes and any deformities. You want shoes that are wide enough to accommodate any deformities. You also want to make sure that patients have footwear that's appropriately padded, that they have cushioned insoles, especially for your elderly patients who have thinning of the fat pads. If you have a patient who has limited range of motion or prior plantar surface ulcers, they may very well need a rocker bottom type shoe, but you would not be making that decision. That would be the decision of the orthotist. So anyone who has a healed ulcer is fitted by an orthotist. Any patient with significant deformities fitted by an orthotist. Patients will frequently ask you, well, what's a good choice in general till I can get in to see somebody to fit me? And in general, athletic shoes are a good choice because they're made either of leather or of a fabric surface that's conformable. So you want a soft, conformable upper. In general, they have a wider toe box. You have to make sure the toe box is deep enough. And then think about socks. It should be cotton or a cotton synthetic blend and clean. The last thing we teach is injury prevention. So we've said this over and over, protective footwear, protective footwear, protective footwear. If you have reduced sensation, if you have compromised perfusion, if your feet are out of the bed, they should be protected by shoes. No sandals, that's not protected. Okay, no open-toed shoes, that's not protected. You want to protect the entire foot, and you want to shake out your shoe before you put it on so you don't inadvertently injure your foot from something that's inside the shoe. We've talked about breaking in new shoes gradually. So for the first few days, you wear them 2 hours at a time and you recheck. And then you graduate to 4 hours at a time and recheck. Don't get in the tub or shower without checking the temperature of the water. Don't get out your paring knife and do any bathroom surgery, because if you sustain an injury, it might be the beginning of the end. You might end up with an amputation. So don't start down the path. Don't do it yourself. Let someone else take care of your feet. You want anyone who's at risk to inspect their feet at the end of every day and to take the temperature, to use that skin thermometer to check the temperature of their foot. If they have an area where the temperature is higher, more than 4 degrees Fahrenheit higher, what should they be doing? Getting their feet checked by a professional. And everyone should have a professional assessment every 3 months. Anyone with diminished sensation, anyone with diminished perfusion. Our goal is to keep them out of trouble. Many times, the most important thing you do for a patient will be an appropriate referral. So we've said this throughout the program, but I'll just summarize right here. When do you refer to podiatry? You refer if the patient has a severe bony deformity and they're interested in at least talking about surgical correction. You refer if they have an ingrown nail that's acutely infected or that you can't manage or that keeps coming back and causes the patient a lot of pain. Any painful foot condition should be referred to the podiatrist. And if you have a recurrent fungal infection, an infection of unclear etiology, they should be referred. If they have a suspicious lesion, they should either go to podiatry or dermatology. What about referrals to the podorthist, the orthotist, the people who create footwear that's custom made for that individual, or they take their footwear and modify it with insoles? Any patient who has significant foot deformities, any patient with recurrent callus, any patient who excessively pronates or has very abnormal wear patterns on their shoes. You know about when to refer to vascular, anybody with lower extremity arterial disease, lower extremity venous disease. If you're a foot care nurse but not a wound care nurse and the patient has a wound, then those patients would get referred to a wound care clinic or a wound care nurse. If you're a CWOCN, you are the wound care nurse, so you can just switch hats and take care of your wound. So in summary, be really clear about who does what in your program. Make sure that other nurses working with you to provide foot and nail care are appropriately educated. Make sure that there's a heavy emphasis on assessment and patient education in addition to the services you provide. Pay critical attention to maintaining infection control, managing your equipment appropriately, as well as protecting yourself, and monitor your outcomes. Thank you.